Eating disorders are characterized primarily by maladaptive eating patterns that lead to distress and functional impairment. In this snapshot, we will be providing a basic overview of diagnostic criteria for eating disorders, including anorexia nervosa, bulimia nervosa, avoidant restrictive food intake disorder, binge eating disorder, and pica. Eating disorders are a group of disorders that can present in a variety of ways. A person can present with obsessions about food, body weight, or body shape. They may present with changes in weight or behaviors around eating, or medical or nutritional problems that have resulted from eating behaviors. Sometimes they may not present unless someone else raises concern about the behaviors. It's important to understand that eating disorders don't discriminate. They affect any sex, any age, any race and ethnicity, and any body type. Let's add some data from the National Association of Anorexia and Associated Disorders. There's a common stereotype that eating disorders are a woman's problem, but an estimated 25% of eating disorders are men. Women are 5 times more likely to be diagnosed. Men are less likely to recognize symptoms as problematic and more likely to have symptoms minimized by healthcare providers. By the time they present for treatment, symptoms in men are often more severe. Eating disorders commonly begin in adolescence, with 60 to 70% of girls trying to lose weight by age 14. About 12% of adolescent girls have some type of eating disorder. However, eating disorders are not just disorders of young women. Life changes in menopause can worsen eating disorders in later life, with over 40% of women over 50 reporting current or previous eating disorder symptoms. Black, Indigenous, and people of color are affected by eating disorders at similar rates as white peers, but half as likely to be diagnosed and less likely to be asked about eating disorder symptoms by doctors. Members of the LGBTQ+ community are more likely to develop eating disorders, with LGBTQ+ youth 3 times more likely than their straight peers. Less than 6% of people with eating disorders are underweight. There used to be specific BMI criteria for diagnosis of some eating disorders, and people who meet those criteria are more likely to get treatment. However, those BMI requirements for diagnosis don't exist anymore, and there is better recognition that people with larger bodies are at higher risk of using unhealthy weight control behaviors. Now that we have some baseline knowledge about eating disorders in general, we will transition into the diagnoses. Before you diagnose any primary psychiatric diagnosis, you first need to rule out normal, medical, and substance or medication-related possibilities. In assessment of a possible eating disorder, asking about the current behaviors in relation to baseline is helpful. When did it change? What is different now? Make sure there is access to food, as restrictive eating patterns can be a sign of food insecurity. Some patients may not talk about this unless specifically asked. Assess if the eating patterns are part of a religious or cultural practice, such as fasting, which would not be considered to meet criteria for a psychiatric disorder unless there is a significant deviation. If you need more clarity, do some research and ask for collateral information to understand typical cultural practices. Get a sense of how the symptoms are impacting their life and functioning, as this is often part of the definition of a disorder in psychiatry. Several medical processes present with changes in eating behaviors and weight. A few common medical causes are listed here, but you need to be guided by your patient's history and presentation, with judicious labs and additional workup and referrals as indicated. Some medical conditions, such as diabetes, may increase risk for developing an eating disorder, in part due to the focus on diet needed as part of disease management. Working with a dietitian can be helpful. It is also worth mentioning that eating disorders can lead to medical complications, so monitoring for secondary medical effects of eating disorders is also really important. Consultation with a dietitian and other subspecialists may be needed. Medications and substances can affect eating behaviors and weight, either by direct or side effects or symptoms of withdrawal. You also need to assess whether the individual has another psychiatric disorder which would better account for weight or appetite changes. Eating disorders are characterized by changes in eating behaviors and often weight. Appetite changes are a feature of mood and anxiety disorders. Some individuals with autism spectrum and other neurodevelopmental disorders may exhibit particular eating patterns that can overlap with certain eating disorders. Comorbidity in psychiatry is the norm. About 70% of people with eating disorders will have one or more psychiatric disorders, often a mood or anxiety disorder that also needs to be addressed. The first eating disorder we will talk about is anorexia nervosa. Anorexia is defined as restriction of food or energy intake relative to one's metabolic demand. This leads to significant weight loss because the body cannot sustain what is minimally required for a person's age, sex, developmental trajectory, and health. In children, failure to gain weight at appropriate intervals may be a sign rather than weight loss. A core feature of anorexia is the intense fear of gaining weight or becoming fat that drives one to restrict food intake. Food restriction continues even though the individual has lost significant weight. Another core feature is a disturbance in the way one experiences their body weight or shape. Individuals with anorexia may give overemphasis to their weight in their overall self-view or may not recognize the severity of weight loss. There are two subtypes of anorexia nervosa. In the restricting subtype, the weight loss is primarily accomplished through dieting, fasting, or excessive exercise. Binge eating or purging behavior has not been present during the last 3 months. In the binge eating purging type, the individual has engaged in repeated episodes of binge eating or purging behaviors in the past 3 months. Examples of purging behaviors include self-induced vomiting, misuse of agents such as laxatives, diuretics, or enemas. Now let's contrast anorexia with bulimia nervosa. Unlike anorexia, bulimia is characterized by recurrent episodes of binge eating. These episodes are defined as periods of time during which a person eats much more than what most people would eat in a similar time frame and circumstances, and during that time period, the individual loses control over their eating. In addition, individuals with bulimia engage in behaviors such as self-induced vomiting, misuse of laxatives, or excessive exercise that are intended to mitigate the effects of binge eating. We call these compensatory behaviors. The binge eating and purging episodes occur on average at least once a week for at least 3 months. And like in anorexia, one's self-image is extremely influenced by their weight and body shape. The third eating disorder we will cover is avoidant restrictive food intake disorder, or ARFID. ARFID is characterized by eating behaviors that result in failure to meet appropriate nutritional and/or energy needs, so similar to anorexia. Examples of behavior include lack of interest in eating or food, avoidance or refusal of a food based on sensory characteristics, or concern about unpleasant consequences of eating, so perhaps fear of something making the person sick. The failure to meet appropriate nutritional or energy needs is characterized by weight loss or failure to gain appropriate weight in children, nutritional deficiencies, dependence on nutritional supplements for appropriate growth, or interference with psychosocial functioning. ARFID, however, differs from anorexia and bulimia in that there is not prevalent body image distortion or hyperfocus on body weight and shape on self-image. Binge eating disorder is the most common eating disorder. It has similarities to bulimia in that it is also characterized by episodes of binge eating that occur at least once a week for at least 3 months. Binge eating episodes are defined exactly the same as in bulimia nervosa. In binge eating disorder, at least 3 additional symptoms are present, including eating much more rapidly than usual, eating until feeling uncomfortably full, eating large amounts of food despite not feeling physically hungry, eating alone out of shame and embarrassment over the binge episodes, or feeling disgusted or guilty after binge episodes. Some of these behaviors may also be present with binge eating episodes associated with bulimia. However, unlike bulimia, there are no compensatory behaviors in binge eating disorder. The last eating disorder we will describe in this video is pica. Pica is the eating of non-food items for at least a month. You would not make the diagnosis of pica in, for example, a 9-month-old child who starts exploring everything in the world with their mouth, because this is developmentally appropriate in that age group. In pica, the behavior needs to be inappropriate for the person's developmental level. It also needs to be persistent, not just a one-time occurrence. In cases of suspected pica, it's important to evaluate what can be driving the urges to ingest these non-food items. Pica is fairly common in people with iron deficiency who might eat dirt and rocks. It's equally important to evaluate for medical complications resulting from what that person is ingesting. For example, a person eating dirt and rocks may also need to be evaluated for parasites, lead, or intestinal blockage. Here's where the eating disorders fit back into the big picture. To summarize, anorexia is characterized by excessive weight loss and intense fear of weight gain. There is no minimum duration for the symptoms for diagnosis, but enough time has to elapse to demonstrate weight loss. ARFID is also characterized by weight loss or not meeting nutritional goals by restricting food intake, but the primary motivator is not fear of weight gain. Bulimia nervosa is characterized by periods of binge eating and compensatory behaviors that occurs weekly for at least 3 months. Binge eating disorder also has periods of binge eating at least once per week for at least 3 months, but there is no compensatory behavior present. Pica is ingestion of non-nutritive substances that occurs habitually over at least a month. It often represents an underlying medical problem, such as a nutritional deficiency.